Oh, well, hello everybody. Good morning. Thanks first to my chairman, thanks to everybody here, and thanks for having me in this really great initiative. I need to congratulate Dr. Juwairiya Ali for this such great initiative. Today, I'll be talking about dyslipidemia management and is there any differences in gender. I couldn't skip this slide. This is, if whoever of you haven't seen this yet, Leicester University, this is the Times News, has surpassed Oxford University, the mighty, in terms of research power. And I'm privileged to be part of the uni, and I've had a few publications under the umbrella. I have no disclosure towards this talk. And my goals today, I'm going to talk briefly about gender difference, historic review for atherosclerosis and statins, treatment evolution, current evidence, and what are future trials. I'll try to cover that over the next 20 minutes. If you have any burning question, please feel free to stand up and ask the question. It's a striking and tragic that in this editorial in 2022, in Circulation Research, Natalie Billow, she has written this. Although perplexing, such sex differences are not surprising to those of us grappling with parallel conundrums in cardiovascular research. And look at this staggering statement. Compared with men, cardiovascular disease in women, risk in women, is increased to a greater extent by some traditional factors. I mean, we are in 2022. We're not in 1921 when the first female in the UK was allowed to vote in the parliament. So we are in 2022, and yet we still have that statement in this editorial. Furthermore, more and more sad statements. This is a publication, Circulation, in 2012, looking at sex-gender differences in cardiovascular disease prevention. What a difference decade has marks. And look at this conclusion. It seems to be in 2007, this is the United States, women accounted for over 60% of US strokes death. And more. This is another publication, American Journal of Cardiology in 2015, talking about gender disparities in evidence-based. And what's been the outcome? Women with cardiovascular disease were less likely than men to receive statins. Look at the difference between the two groups, or high-intensity statins. And furthermore, the mean low-density lipoprotein, the LDL mean in female, is higher as a fact than in men. This is, as you can see, in milligram per deciliter units, the mean in women is 99, nearly 100, versus 85 in men. And in adjusted, this paper in American Journal in 2015 concluded in adjusted models, female gender was independently associated with lower likelihood of receiving statins or high-intensity statins. Look at this, the odd ratio is 0.68 for a lady to receive a statin. This is really staggering facts. Another one, this is in 2014. Gender difference in achieving optimal lipid goals in patients with coronary artery disease. Without going through the conclusion statement, just in conclusion, women with coronary artery disease are prescribed insufficient doses of statins and combination lipid-lowering therapy and are less likely to achieve their optimal LDL and non-high-density lipoprotein cholesterol goals. This is paper in 2014, which massaged data, national data in the US over 10 years. So I'll skip this slide because I think this is more contemporary, and I'll talk towards the end about it. I'll touch on it at the end with the difference in outcome in patients. Now, just go back to our goals. I think you've seen this pie chart many times. Cardiovascular disease remains the main killer. This is a fact. This compared to cancer, compared to any other disease or car accidents, cardiovascular disease remain the main killer. And we need to pay more attention towards devastating disease or pathology. These are, I've tried to highlight the landmarks in the last century, talking about dyslipidemia, our understanding, the concept of cholesterol and atherosclerosis and how we evolved over the last more or less 100 years. There were three landmarks I could find. Number one, in 1913, this histopathologist, Professor Anishtkov, he correlated in his histopathology studies the relation between cholesterol and atherosclerosis. And I think that was quite start for us to start understand that cholesterol is bad for us. The next landmark timescale was in 1961, which we're all familiar with, Framingham's study, in which cholesterol was defined as major risk factor for cardiovascular disease. The next one was the Nobel Prize award to those two scientists, Brown and Goldstein, in 1985, where they established the regulation of cholesterol metabolism. In my view, those are the three landmark timescale points in which we started to establish the cholesterol relation to atherosclerosis and how we can start managing it. So this is when they released, this is where the main research study before it was published around the globe, because it's the impact it has on the entire human race. Now, coming to the statin or management of cholesterol, we've established the concept that cholesterol is bad for us and it's a very solid risk factor for cardiovascular disease. Well, statins, when did it start? I think very few of us knows that the very first statin was discovered in 1976 from this plant in Japan called Indo. And it took 11 years to market lovastatin at that time when we first statin in the globe started that stage. Now, we have a barrage of data, I'm sure we're all familiar with this, on how beneficial the statin is. And I think one of the main benefits, perhaps over the last 4 decades in terms of a treatment, perhaps statin stands out among everything else. This is the 4S trial. Probably be all familiar with this. In Lancet 1994, over 4,000 patients were randomized between simvastatin and placebo. And look at the difference that has made a small dose of simvastatin, 30% reduction in all-cause mortality and 34% reduction in major coronary events. And I need to highlight to you, look at the achievement of LDL level here. You can see they're nowhere near where the European and the American guidelines indicate. What we aim for now is way, way far lower than the goals that achieved in the 4S trial. Yet, they've resulted in over 30% reduction in mortality and cardiovascular events. Another landmark trial, the CARE trial. We're all familiar. The statin was used, which we rarely use these days, the pravastatin. Published New England Journal 1996. Again, over 4,000 patients. They looked at pravastatin versus placebo. And the outcome, the primary outcome, was fatal coronary heart disease or non-fatal myocardial infarction. And the reduction is 24%. This benefit, we don't see it that often in pharmacological trials. This is the first trial, though, despite the fact using pravastatin, that had shown that we can drop the LDL below 100 milligram per deciliter or 2.5 millimole per liter. The next trial was another landmark published in New England Journal, Cannon et al. That's proved it, TIMI 22 trial. Again, pravastatin versus atorvastatin 80. No matter what you think about this comparison, I think there's a lot of criticism. However, the fact this trial has established the concept of intensive lipid-lowering treatment based on this trial. The high-dose statin, 80 milligrams, has resulted in further benefit for patients already on statin, pravastatin 40, with reduction of 16%. So this is the very first trial that has established the concept of intensive lipid lowering is essential and crucial in our treatment to our patients. The next trial, Improve It 2014, which what I call, I think it's a scandal in the history of medical research. This is a trial, I'll talk about it briefly. It took 7 years to show 1% improvement in patients who had added ezetimibe to their simvastatin in group of acute coronary syndrome. So despite all this, this trial has resulted in changing the guidelines, and it's been shown straight away after the trial to be added to the guidelines. You need to add ezetimibe to your patients who are already on statin. I think you can take whatever you want from it, but it's still in the guidelines. And I think the straightforward answer for our patients, we start the statins plus ezetimibe straight away. And if they need further reduction, then we move to the PCSK9, which most of us are using already. The LDL and its importance in terms of outcome in cardiovascular outcome in our patients. It's crucial to remember this statement. You've seen it many, many times. This is built on a number of trials. We've seen this, the HPS, CARE, Lipid, 4S trials. You can see in yellow is the placebo, and in purple is the statin arm, despite the fact there are various statins. You can see a linear relationship between LDL and cardiovascular outcome. So the magic statement is every 39 milligram per deciliter or 1 millimole per liter decrease in LDL cholesterol decreases relative risk for coronary heart disease by 20 to 25%. Remember this, when you look at your patient's LDL on your screen, every time you see them in your clinic, remember, we need to drop these numbers. That's how they benefit our patients. Now, a lot of people, you've heard a lot of talks in terms of dyslipidemia, talk of non-HDL, about lipoprotein, about multiple other factors, HDL. The European guidelines in 2021 states it clearly, with the level of evidence of 1A, LDL is the core for our treatment. Forget everything else. LDL is the goal target. Everything else, the evidence behind it range from 2A down to 3 even. When you look at we heard this many, many times, looking at apoprotein A and so on. Those are class 3C, so you're not benefiting your patient when you consider those factors. Remember this, LDL is the core. This is just a complementary study done in the UK. It's probably most of us familiar with the UK prospective diabetes study. And it was conducted looking at weighing the factors, which one among the other risk factors, which one is the most important one. And as you can see on the right-hand side, the number of zeros favors the LDL by a distance from all the other factors, including smoking, hypertension, HbA1c. So LDL, again, one more time, is the most important factor we need to address. So, just in summary, fundamentals so far, what we've done, atherosclerotic cardiovascular disease remains the #1 cause of death and disability in adults worldwide. LDL cholesterol is the most important risk factor for the development and progression of atherosclerotic cardiovascular disease. It is the cause. There is no other factor. The relationship to cardiovascular events is a cause relationship. LDL is the only factor. No lower threshold has been identified beyond which LDL lowering is no longer effective. Remember this, we do get, all of us I think, we do get a call from the general practitioner or another cardiologist saying the LDL is too low now. And my reply is always, for God's sake, just keep it as it is. As low as it is, it's good for your patients. Now, I'll just touch briefly with this one slide on plaque regression. I think this concept we need to explore more and more with the new available treatment that's merging into the market these days. Specifically, I think the PCSK9. The plaque regression is key for our patients because all starts with the plaque. All the events start with the plaque in your patient's heart arteries or carotid arteries. We won't start, I won't touch on this one. We've seen it in many, many textbooks. Well, we won't start at this stage here. We need to check our patient's lipid profile. Now, the NICE guidelines in the UK indicates for every GP to check the lipid profile for every person, not patient, at relatively very young age. We talk about age 20s, when they are starting their universities. I won't go too much into this details, but this is a fancy, color-coded virtual histology. I'm sure we've seen a lot of us, we've seen some of this. This is a color-coded to define the plaque structure. And it was done very early 2000 by a guy from Liverpool and Vino Ramani, where she defined on histopathology the plaque structure. And the guy who studied physics in Liverpool University, he coded the signal, the ultrasound signal coming from the intravascular ultrasound into 4 different colors. And just without any details, if you want to have a plaque in your artery, I would choose this one, the very first one. I wouldn't go anywhere near this last one, rich lipid core and everything else, all the factors that defines unstable plaque. I mean, do I need to talk about this slide? It's just scandal for us. How much we achieving lowering LDL. And I think there is a data from Dr. Hani Sapur and from our chairman stating clearly that we are under-treating our patients by distance. Not only just the level, the number of patients that need to be treated who are not receiving the right treatment is huge, and hence the risk is phenomenally high. This is just to touch on the fact that inpatient, remember the plaque is the key, with acute coronary syndrome, once they start to have their first event, despite the intense treatment, as well as revascularization, we do everything for those patients, their risk events or event rate remains high, despite all the treatment that we have. And we still way, way away from achieving very low mortality rate. You're talking about 10 to 11% mortality rate over 1,000 days in any patient had an event rate start with, whether it's a stroke or myocardial infarction or acute coronary syndrome. Now, I think in 2003, this is the new century. We're talking about the 21st century. And I'm going to define this, mark my words on this. This is one of the definite points, landmarks in our treatment for cardiovascular patients and reducing the risk in those patients. The discovery of this molecule, which was called first NARC1, was invented, basically it was discovered as a liver regeneration and neuronal differentiation. So totally nothing to do with cardiovascular or LDL or whatsoever. Eventually, we've learned that we have seen this LDL receptors. The concept is we have a limited number of receptors in our liver cells. They're not renewable. And what they do basically, they surface, capture the LDL, go down to the sarcoplasm, and then be discarded. So you discard the LDL, resurface again. This is how we get rid of our LDL. So we discovered that this bad boy, called PCSK9, binds to our receptors, to the LDL receptors, and just move into the endosome and lysosome, and eventually they will destroy the entire component, including the LDL receptors. Hence, the number of LDL receptors will keep going down and down unless we find something to inhibit the PCSK9. Now, of course, the pharmacological companies will grab this opportunity and say, yes, we will work on this to try to tackle this bad boy. And I'll show you the very first 2 molecules that have been invented as inhibitors for the PCSK9. We know the monoclonal antibodies. And we've had 2 landmark trials looking at inhibition of PCSK9. What's the outcome? Fourier trial and Odyssey trial. I think we're all familiar with those, despite the fact they are not the same group of patients. We know the Odyssey trial using acute coronary syndrome patients. Fourier was more stable patients. both of which those trials, without going into details, trial design and everything else, showed massive benefit for our patients in terms of reduction of mortality and cardiovascular events. This is, we're talking about monoclonal antibodies for PCSK9. I won't go through this because it's quite long, and I think we've touched on it many, many times in the past. The Odyssey trial, those two trials, they've led to a quite radical change in terms of European guidelines. And I'm sure all of us who were in Paris in 2019, the highlight of the ESC that time was talking purely about the PCSK9 monoclonal antibodies and their impact. They've changed the target LDL, and it has, that time, it was the lowest ever being recommended by the European Society. As you are familiar, very high risk at the time, this is 2019, the very high risk group, we started to drop to less than 1.4 millimole per liter, the high risk group less than 1.8, the moderate risk less than 2.6, and low risk less than 3. This is 2019 ASC guidelines. This is the level of evidence we're talking about as secondary prevention, class 1A, and start the PCSK9, get their way into the guidelines, as you can see with the class 1A evident as an add-on treatment. Now, the next step was the invention of inclisiran. This is a different modality or mechanism of inhibiting the PCSK9. And the beauty about it is it's targeting the messenger RNA, which I think is the future of any pharma treatments. We know that there is some evidence in the cancer treatment, but more and more these days, we are learning about the messenger RNA perhaps will be the future treatment for any medication, as it targets specifically certain protein production inside the plasma, inside the cells, and results in hardly any side effects. One of the reasons why inclisiran specifically works in the liver, look at these specifications. I'll read this number 2 of them. The target messenger RNA is subject to degradation in the cytoplasm and not in the nucleus, so it doesn't affect the nucleus. Conjugated with GA1 NAC for specific uptake by hepatocytes, where it's internalized by endocytosis. So that's why we've got something that powerful in reducing LDL, and I'll show you some data on this, and yet has very minor side effects. Again, this durability of the inclisiran has been immense in terms of formation of the inclisiran RISC complex, protects inclisiran and enhances its durability. I want just to show you something. Inclisiran plasma levels decline within 24 hours from the injection and are undetectable within 48 hours. So nothing is remnant inside the plasma, all within the hepatocells. Now, we've got a barrage of Orion data trials from phase 1 to phase 3, and they've shown all of us the significant reduction in LDL, which again, I'll go back to this as the core for our reduction, our patients' reduction in cardiovascular risk. The significant reduction, which exceeds over 50%, has resulted in certainly clinical benefit. And I'll show you, without going the trials data, because I think there's so much of them, and we're going to learn about them more and more. The one fact here is, in this one, regardless of the baseline treatment, inclisiran has resulted in significant reduction. As you can see here, inclisiran is better than placebo, whether you are on statin or not on statin. This might be an idea for the future trials, I think, and I think a lot of us talking about perhaps using PCSK9 alone at some point and compare it to statins. The inclisiran has not just lowered the PCSK9 level, it has lowered all the suspects, total cholesterol, non-HDL cholesterol, apoprotein B, lipoprotein A, all those factors being reduced quite significantly. We talk about 40% reduction in non-HDL cholesterol.
Albert, we're running out of time.
I'm going to conclude shortly.
Right, thank you.
I won't go through the Orion. There is a lot of this one, but I want to show you something that has led to massive change, particularly in the UK. This is, you've seen in the UK, published in all national journals, the UK NICE guidelines recommendation. And I was privileged at some point to be one of the members of NICE. And I know literally how rigorous we have to be in order to approve any medication. So then for the NICE guideline, for the NICE to approve a medication, they have to rigorously visit the data. And they approved for every single patient with high-risk group to be added onto their treatment at very young age. So the GPs, the general practitioner, they don't have to come to see me or see any of you. They only need to see the GP to have this prescribed. So without further ado, for take-home messages, I think atherosclerosis disease is preventable disease. We are learning day after day, it's preventable. If you treat your patient LDL, they're gonna live longer, they're gonna last longer. We've seen some of Dr. Hani's support talking about Eugene Bromwald said, do you want to live till 100? I'm not sure I do want to live if I lose my sharpness, but I think we can live till 100 now. More emphasis on lowering LDL in women, please. This is our sisters, our mothers, everybody. We need to treat them equally. LDL target is less than 1.4 in secondary prevention and in high-risk primary prevention. The goal has to be achieved. The LDL goal, remember, the lower, the better for our patients. We're talking about in a very high-risk group. The ASC guidelines recommended less than 1 now, LDL. Future trials, I'll talk about that's for another session. This is a fascinating session. We need to be more proactive and look at the plaque and its relation with the clinical outcome with any new drug appearing on the surface. Thank you very much.